Welcome to e-learning for NIVATS. This module takes 10 minutes to complete. NIVATS, or non-intubated video-assisted thoracic surgery, is currently being piloted in NUHS. NIVATS involves performing VATS surgery without lung isolation in spontaneously breathing patients. Surgery can be done under monitored anesthesia care, supplemented with regional anesthesia. In NUHS, patients undergoing NIVATS are given a general anesthetic. A supraglottic airway is used for airway management, thus avoiding the need for endotracheal intubation and its associated complications. Regional anesthesia is used in these cases with GA to provide a balanced anesthetic technique. These include paravertebral block, erector spinae block, or intercostal nerve blocks. What are the advantages of NIVATS? Some of the potential benefits include reduced airway trauma, decreased inflammatory response, and reduced barotrauma to the lungs, as positive pressure and one lung ventilation are avoided. These can lead to better outcomes for patients in terms of faster recovery and earlier discharge from hospital. We can now look at our locally developed clinical guidelines for practice of NIVATS. These guidelines are available on the NUHS intranet in the Department of Anesthesia section. It outlines requirements for the safe practice of NIVATS and includes information on patient selection criteria, workflow, equipment required, and dealing with emergencies. As it's a new procedure for us, we are conducting training sessions for all AU and scrub nurses who may be involved. Patients for NIVATS will be identified by the thoracic surgeon. Anesthesia pre-op evaluation will be carried out in AOCC to confirm suitability. Exclusion criteria are extensive at present, but can be relaxed once we obtain experience in NIVATS and are confident with our workflow and clinical processes. Exclusion criteria include patients with severe OSA, morbid obesity, potentially difficult airway, poor baseline respiratory function, and patients with major systemic disease such as cardiac failure, end-stage renal failure, and liver cirrhosis. Complex lung lesions involving the major bronchi, chest wall, or diaphragm are also excluded from NIVATS. Patients undergoing NIVATS are not paralyzed and are spontaneously breathing. Anesthesia needs to be tailored in order to provide surgeons with a stable surgical field, with minimal movement of the diaphragm, chest wall, or mediastinum. On the converse, excessive depth of anesthesia may lead to hyperventilation, hypoxia, and hypercarbia. A balanced anesthetic technique using TIVA and regional anesthesia is used, titrated to a respiratory rate of 12 to 20 and BIS of 40 to 60. The preferred supraglottic airway for use in NIVATS is either the Oragain or iGel, as these allow for passage of a fiber optic bronchoscope and bronchial blocker, should there be a need for conversion to one lung ventilation. Coughing may be an issue during surgical manipulation. This can be dealt with by a vagal block, performed by the surgeon. A standard anesthesia plan for NIVATS is described here. This table shows the additional anesthesia and surgical equipment required for a NIVATS case. It is important that we have the airway trolley with listed equipment available in the OT at all times. To summarize, we will use either the Oragain or iGel supraglottic airway for airway management. The disposable ambuscope size 3.8 should be available in OT, although it does not need to be opened from packaging. A video laryngoscope must also be available at all times. Additionally, an adult-sized uniblocker and 37 French left-sided DLT should be available, should the need arise for conversion to one-lung ventilation. Also required are an ultra and regional block trolley, as well as 2 TIVA pumps. On occasion, there may be a requirement to convert from a spontaneously breathing patient to positive pressure ventilation and one-lung ventilation. This is estimated to occur in less than 5% of patients. The reasons for conversion can be broken down into surgical and anesthetic indications. Excessive mediastinal or chest wall movement may make operating conditions difficult, thus necessitating controlled OLV. Unexpected bleeding and dense surgical adhesions are other indications. Anesthetic indications include persistent hypoxia or significant hypercarbia, associated with respiratory acidosis or hemodynamic instability. Some degree of permissive hypercarbia is usually tolerated well by patients. In awake patients, GA may need to be induced if they are uncooperative or unable to tolerate surgery. Conversion to one-lung ventilation can be carried out by a number of methods. Often the technique chosen will depend on the patient and situation at hand. Outlined are 4 methods that can be used. Planner involves lung isolation using a uniblocker inserted through the supraglottic airway. The ambuscope is used to guide the blocker into final position, and the balloon is inflated under direct vision. The patient is paralyzed and one-lung ventilation proceeds through the supraglottic airway with blocker in place. Failure to achieve satisfactory lung isolation with this method leads us to Plan B. In Plan B, an appropriately sized endotracheal tube is railroaded over a bronchoscope through the supraglottic airway. We can proceed to block the appropriate lung once the endotracheal tube is in the trachea, and ventilation confirmed. Lung isolation can be achieved with the uniblocker as previously described, or by passing the endotracheal tube into the appropriate main bronchus to be ventilated. The table shows ETT sizes for different sized supraglottic airway. If Plan B fails, an attempt can be made to intubate the patient in the lateral position, either with a single lumen endotracheal tube or double lumen endotracheal tube. The bed can be tilted slightly to bring the patient's head and airway to a more supine position. A McGrath or CMAC video laryngoscope should be used to visualize the glottis. A bougie can be used to facilitate intubation if required. In an emergency situation with impending or total loss of airway control and ventilation, an emergency maneuver to turn the patient supine to facilitate intubation must be quickly carried out. The phrase, "cover and turn," is used to alert all members of the team to the need to act quickly. The surgical wound is covered with ioban dressing before turning the patient. Once the airway has been secured, the patient is turned back to the lateral position to allow surgery to continue.
This video demonstrates one-lung isolation with a uniblocker. The blocker is inserted through the supraglottic airway under direct fiber optic vision.